それでは続きまして
Let us move on to start the second part of the program. First, from Institute of Developing Economies of JETRO Area Studies Center, Chief Senior Researcher Mr. Hirano will take the stage. My name is Hirano. Thank you very much for coming to join us this afternoon. And to the people at JCIE, starting with President Shibusawa, thank you very much for co-organizing this event. I have been an African researcher for 30 years. I have been looking at the issue of AIDS on the ground. AIDS was a symbol of hopelessness of Africa at one time, but currently, today, there is a system in place. Having looked at these developments myself, how was this system developed? What kind of organizations around the world are involved in developing this system for AIDS? We're trying to get that answer, and by reading the book written by Dr. Piot, I can understand that. When a history is made, there are heroes. How the humankind was able to deal with this problem and fight against this problem in Africa, you can really understand that by reading this book. Economics, development, and area research is what we do at IDE, at JETRO. As part of what we do, we have been fighting against this issue of AIDS in our own way. We have people from the corporate sector in the audience. This disease, AIDS, is going to eat at the society, and it will have a negative impact on economic activity as well as activities of corporations, starting with the World Bank. We have a senior economist, Dr. DeWalk, from the World Bank. We would like to ask him to talk about this issue of AIDS as well as the impact on economic activity. Dr. DeWalk, please.
Good afternoon, and thank you very much. And I'm very honored to be invited to this symposium. What I'll try to do with you this afternoon is give a brief overview of the impact of HIV/AIDS on labor markets, and especially in Africa. And I'll first try to discuss what is so specific about AIDS and AIDS mortality compared to other diseases. And then, building up on the discussion by Dr. Piot that highlighted how the arrival of AIDS treatment, what is called antiretroviral treatment, had such an impact, I will look at the situation before AIDS treatment and then try to see how the arrival of AIDS treatment changed basically the impact of that AIDS had on labor markets. And I'll use specific studies in African countries, in Southern Africa and in Kenya, and then in Botswana to illustrate that. And I'll finish with going back from treatment to the need to continue prevention of new HIV/AIDS cases. So what is so specific about AIDS mortality? And that was part of the discussion before. And it's true that if we look at the burden of disease in the world, well, HIV/AIDS is an important part of the picture, but TB is almost as big, and cardiovascular disease the number of deaths, of yearly deaths, are much higher. The same for deaths related to smoking or even violence and injuries. But I think what is quite specific about AIDS is that compared to other diseases, AIDS tend to kill relatively young and productive people. And I'll illustrate that with some data from demographic and health surveys in 5 African countries, Burkina Faso, Cameroon, Ghana, Kenya, and Tanzania. And this picture shows the age profile of HIV infection. And what you see, this is for males, is that really the high prevalence age are between age 25 to 29 and age 40, 44. And we know those are the ages where people are most productive in their career. It's the age where they have children, where they educate those children. So compared to other diseases that tend to kill either young children or older people, AIDS is really specific because it kills people in their prime ages, prime productive ages. And we see the same picture in the same countries for females. Basically, it's prime age adults that are affected by AIDS mortality. So, and we'll see that in following two examples before the scale-up of AIDS treatment, looking at how AIDS was affecting labor productivity and the cost to business. And I'll start with an example from Southern Africa. Rather, I'll describe the results from a study by Rosen, Vincent, McLeod, and others that compared 6 companies in South Africa or in Botswana in different sectors, heavy industry, agriculture, mining, retail industries, and the media. And you see they're either from South Africa or specifically in South Africa, the province of KwaZulu-Natal, or from Botswana, different size of the workforce, and the estimated HIV prevalence in these different companies was different from, and sometimes very high, like this mining company in Botswana with a prevalence of 31.6%. And they were looking at what is the cost to those firms of AIDS. And they basically categorized the firms in 2 categories. Those with a high cost and those with a lower cost. It really depended on 4 criteria. The level of death and disability benefits offered by the companies, whether they were large and stable benefits, or whether the benefits were declining over time, the kind of medical care that was offered by the companies, the status of the unskilled worker, whether they were permanent employees or whether many were part-time contractors, and also the level of salaries. And when the salary was higher, so absence and turnover, change of employees cost a lot more. And so comparing these 6 companies, they basically looked at the distribution of cost. And the cost could be divided into the cost related to leave and absenteeism in yellow, productivity loss in blue, retirement and death and disability in red, and in this other kind of blue, other shade of blue, the costs related to medical care, and then recruitment and training in purple. And you see that depending on the type of the firm, for the one company with low cost, basically most of the cost is related to leave and absenteeism and productivity loss. Whereas for these more formal companies, or with better benefits for the employee, the large share of the cost is related to retirement, death, and disability benefits. And if I go to the next slide, you'll see that not only is the distribution of cost is very different, but also what is very different is the size of the cost. So actually, if you take the actual size of the cost, then that's the cost for company A compared to the cost for company B. So it really depends on the type of company and the type of benefits given to the employee. But I stress this was before the arrival of the scale-up of AIDS treatment. So there was another study more specific about a tea plantation in Kenya, in this paper by Fox, Rose, and McLeod and others, that looked at the impact of HIV/AIDS on labor productivity in Kenya. And the objective of the study was to determine the distribution of deaths in the workforce of a large agricultural firm in Western Kenya and estimate the decline in on-the-job labor productivity associated with HIV/AIDS. It's the company is tea estates owned by a large agribusiness company in Kenya. It has 10,000 tea pluckers, 79% of them are males. And what is interesting for the study is that they are paid by kilogram of tea leaf plucked. So it's every evening, basically we know how many kilograms of tea leaves have been plucked, and it's quite easy to measure productivity. There was free on-site medical care for all workers and their dependents, and the workers were getting paid sick leave. There was HIV testing and counseling available, but few accepted to be tested at the time of the study. At the time of the study, the company was treating for opportunistic infection and providing palliative care, but at the time of the study, it was before the arrival of antiretroviral treatment in that area. And what we see, so over the time of the study, there was about 600 natural cause deaths and medical retirement at the company hospital. And we see that over time, the death toll of AIDS was increasing. And you see that every year, it was actually increasing. And even for just 5 months in 2003, the death toll was already higher than the previous year for the previous full year. And to come back to what I discussed before, if we look at the age of people who were dying, again, it was concentrated among these very productive ages, from 25, 29 to basically 44 years old. There was this peak, of course. As often in Africa, you have a lot of young children dying, but really among adults, it was really in these peak productive years that the deaths were taking place. And if we look at the cause of the disease among workers, HIV/AIDS was really the bulk of the deaths, and even among the dependent children, it was also an important cause of death. So what this study does is they study cases who are tea pluckers who died at the company health facility of an AIDS-related causes or were medically retired due to HIV/AIDS. And the controls are pluckers who were working in the same fields over the same time period as the case. And they do that to compare their productivity over time and to see how the productivity of the people who were affected by HIV/AIDS was declining. And it's illustrated in this figure where on this vertical axis you have the average kilograms of tea plucked per day. And those are years before the death of the HIV/AIDS case. And this is when the plucker dies. And you see that the case were always, so the people with HIV/AIDS were plucking less tea on average for a long time. For example, 1.5 years before it was 3.9 kilograms. But that gap increased a lot as the tea pluckers were becoming sicker and were closer to death. So, in conclusion, for the estimates of the loss of productivity, in each of the last 2 years before death, a tea plucker with HIV/AIDS was absent from work 31 days more often. There was an increase of 87%. He spends 22 more days on light duty. He plucks an average of 7.1 kilogram less tea leaf per day. He has reduced annual earnings, because the annual earnings depends on how much they pluck, of 18%, and on average he produced 35.1% less tea in the final year before death. So those were two examples before the arrival of antiretroviral treatment, which is the AIDS treatment. And so now we are going to look at what's happening after that. And before that, maybe I want just to give a few points about the scaling up of AIDS treatment. So maybe it's worth reminding that there is no cure for AIDS, but there is treatment for AIDS, which is called antiretroviral treatment, and it extends the life expectancy, and the quality of life, but it's a lifelong treatment. Once you start on it, you have to take it for your entire life. As of 2012, an estimated 8 million people in low and middle income countries were receiving antiretroviral therapy, and it's in sub-Saharan Africa, nearly 56% of people who should receive it, who are eligible for treatment. You are not eligible as soon as you are infected by AIDS, but as you are eligible when AIDS progresses, were able to access those life-saving medicines. That seems only 56%, but it's actually an extraordinary achievement when one considers that as recently as 2003, only a few privileged HIV/AIDS patients had access to ART in Africa. And so the scaling up of ART in Africa has saved many lives and will continue to do so. What is important to stress as well is that AIDS treatment is more accessible now and way cheaper than before. The cost of a year's supply of first-line antiretroviral drugs decreased from more than $10,000 per person in 2000 to less than $100 in 2011. So that's a huge decrease. In many countries, AIDS treatment is publicly provided and is often free. On average, the donor funding pays for about 84% of treatment costs in low-income countries, but some countries are exceptions, and South Africa is an exception where in South Africa the share of public funding from the government is much larger. But it's still in the employer's interest to provide treatment or health insurance to the employees who do not otherwise have access to what, so that they can avoid the productivity losses that we have documented before. So, as before, I will focus on two studies, but there is a good summary in a recent article published in Health Affairs in 2012 about the economic benefits of providing antiretroviral treatment. They summarize the benefits as follows. For households, there is higher employment rate, lower end-of-life expenditures, and that includes both medical care, but also I don't know if you are aware, but in Africa, people spend a lot of money compared to their income on funeral. And so by postponing that, you can save money. There is less child labor and more schooling for children. And to the employer, their employers are more productive. There is lower absenteeism and lower turnover in the workforce. So in the first example, I'll look at the benefits for the households, and I'll take that from a study by Tirumurti, Graf, Zevin, and Goldstein, looking at the economics of AIDS treatment labor supply in Western Kenya. And they look at a program that provides free ART, free antiretroviral treatment, AIDS treatment to patients, as well as a treatment for opportunistic infection, those other infections that come with AIDS. And to follow this example, it's important. They are going to use a technical term which is called Cd4 Counts. It's a medical measure of the strength of the immune system. And as AIDS progresses, the Cd4 count decreases. But with the introduction of, when the patient starts on antiretroviral treatment, the Cd4 count increases. So high Cd4 count is good, low is bad. Okay? So this is evidence about the mean hours worked in the past week among patients. And here the zero is when, time zero is when they start treatment. Okay? And so you see it was decreasing before, and then it goes back up. There is sort it's a long V shape. There's a rebound. And what would have happened without AIDS treatment is very simple. Simply, the patient would have slowly, his health would have deteriorated, and then he would have died. And of course, that person supplies 0 hours of work. And so here is the picture for the Cd4 count, this measure of the strength of the immune system. And you could see that, and again, 0 here is start of treatment. It was going down before, and it's rebounding. You see this V shape after the start of the treatment. And I'll compare this V shape, this rebound, with other measure of health and then labor productivity. This is the mean body mass index of the patients. Body mass index is a measure of weight relative to height. So because AIDS patients were losing weight, and so you see this rebound after the treatment times 0 here. And you see the same V shape with this rebound after the treatment for the fraction of those patients who are participating in the labor force. So the main findings in terms of labor supply, there was a very large and rapid increase in patient labor supply. among other household members, there was a sizable decrease in the labor supply of young boys. So while the father or the mother was sick, the boys had to go and work in the labor market. And with the start of the treatment that's disappearing, there was no significant change for girls. And even though treatment is free, they estimated in that study that patient earnings are close to the cost of treatment to the health system. So basically, it was, there was a good cost benefit to providing free treatment. Now we are going to look at evidence from a firm point of view, looking at ARV treatment and worker absenteeism in a large firm in the diamond sector in Botswana. And in that diamond company, after observing high mortality and morbidity in its workforce, the company conducted in 1999 the first of a number of voluntary anonymous prevalence surveys that revealed a very high prevalence rate of 28%. In 2001, the company started an ambitious treatment program that provides free and confidential antiretroviral therapy treatment to the company's workforce and their spouses. And so here is an illustration of, as people were getting sicker, so CD4 count of 600 is healthy, as we go from right to left, patients are getting are in worse health, and we see that as their CD4 count decreases, the number of days they are absent increase. Okay? But that's with the introduction of AIDS treatment in that diamond company, we see that that is basically changing. So those are the days absent per month. And again, the 0 is when treatment is started. And we see 12 months before treatment, there was not too many days of absence. And then it's going up as the patient is getting sicker. And now it's going down once we start treatment. So the main result from Botswana is that enrolled workers miss about 20 days in the year prior to treatment initiation. That was 5 times the annual absence duration from illness among other workers. But the introduction of AIDS treatment is followed by a large reduction of absenteeism in 6 to 12 months following the treatment of the beginning, going back to comparable levels, to level comparables to other workers. I'd like to finish with a very short discussion of, so I've highlighted the benefits of treatment, but to stress that prevention is very important. And those are data and projection for Thailand, and we see the cost in millions of dollars of the AIDS treatment. And we see it's increasing over time, and that's because as people are maintained in life, of course, they will need the treatment for the length of their life, but also the red and the green part here are the cost of second-line therapy. So people start on first line, but over time they might develop resistance and they need to be put on second-line therapy, and that's much more costly. And so that's very important to keep that in mind. So I wanted to illustrate this increasing cost over time and the part of the second-line therapy. And so in the long run, the greater the success of treatment, which is really good, the more patients, and more patients means more costly or more expensive treatment programs. And we know that second-line therapy, at least now, is much more expensive. So good adherence to treatment can basically delay the time where patients are put on second line. So it's very important. And there is an important role of health infrastructure and staff. But still, I want to finish by saying that as much as AIDS treatment is a big, big success, it's really important to also prevent new HIV cases. And so I want to finish by saying, prevention needs to be a very important component of the AIDS response. And I thank you very much for your attention.
Thank you very much, Dr. DeWalk. Well, this event, actually, there's going to be a TCAP meeting in June of next year. This is African Development Conference, and this is a related event. at the previous TCAT meeting, what the Japanese government did is Japan made a promise to double our investment into Africa, and many programs were organized and budgets were allocated. But we in the Research Institute, including AIDS issues and other social programs, we asked for enhanced budget for these programs. In my experience, Japanese companies operating in Africa, they are dealing with this AIDS problem, and they're having a lot of difficulty with these infectious diseases. South Africa is where Japanese business have headquarters regionally, and South Africa had 5.7 million people infected with AIDS. So when you have a large operation, you have to understand that there are many HIV-infected people working there. And Toyota has the largest workforce in South Africa. And Toyota, on this issue of AIDS, they have implemented policy, but results were not generated as quickly, and that's the problem that they had. So in response to the Japanese government's policy, we decided to work with Toyota, receiving money from the Japanese government to try to implement the program on the ground to deal with this AIDS issue. We wondered what would be the most effective method, would be the most efficient method to protect the employees there. So that is what we have been working on. As Dr. DeWolf said, around the world, economists are conducting a lot of research on AIDS and infectious diseases. But I think this is the first such research by Japanese people, because we were granted quite a substantial budget. So over a 4-year period on local factory in South Africa of Toyota, we have conducted research on effective labor program there. And the leader of the project, Dr. Seiro Ito, is going to give you a report on the results of that research. My name is Seiro Ito. I'm from IDE of JETRO. I would like to talk about our program, what we did at Toyota in South Africa. This joint research that we have conducted with Toyota is my report. But before I start, I would like to express my gratitude to people at Toyota who have willingly accepted this research. This research was conducted with these members on the screen. Now, South Africa, as Mr. Hirano said, this is a country on the African continent. They have the most developed economy, and very good labor force is existing in South Africa. So in doing production work in South Africa, there's a number of difficult issues. One of them is labor, employment, because South Africa has very strong labor unions. That's a major feature about the country, and it's very difficult to dismiss people. It costs a lot of money to dismiss people. But at corporations, when you want to develop human resources, you want the same people to continue to work for the company. So when you take these two into consideration, when you hire people in South Africa to do some production work, you want your people, you want your employees to continue to work, because it's very difficult to dismiss them. So once you have people on board, you want these people to stay healthy. But in fact, the prevalence rate of HIV is very high in South Africa among the population between age 15 and 49. 16.9% is the prevalence rate in 2008. This is an estimate figure. So when you really think about this number, let me give you some extreme example. Let's assume that new infection rate is close to this rate of 16.9%. If we make that assumption, when you have employee base of 307, then if you do the multiplication, it comes to 52. 52 means this is the number of weeks in a year. So when you don't provide any treatment, then 52 people every year will be newly infected. And if you don't provide any treatment, these people will eventually die. So when you have a company this size, it means that every week, one person of your workforce will be dead. So when you have 300 people, of which 52 people will get infected every year, then when you don't provide any treatment, it takes about 10 years from infection to death. So 10 years and plus 6 years, all of your entire workforce is going to be replaced because of this disease if you don't provide any treatment. That is what math tells you. So at corporation level, what can you do to fight HIV? First of all, you need to identify and detect HIV patients and provide a treatment. This is step number 1. So we wanted to urge people to take tests, and with the purpose of identifying HIV-infected people, we worked with Toyota, and inside the company, there was a question raised saying that when you find who is infected, what do you do next? This is a very good question on the point. So ultimately, we were able to do this because treatment was guaranteed. As for drugs for treatment, South African government provided subsidies plus global fund subsidies. So drugs were provided to Toyota free of charge. So we would detect HIV patients and provide treatment to prevent secondary infections. So that is step number 1. The second purpose for this program is that amongst the non-infected people, we wanted to identify people at most risk to try to promote prevention. So the next question is, how do you go about detecting who is infected? And the second question is, how do you identify high-risk group people amongst the non-infected people? So these are the two challenges that we have faced. Please look at this diagram. High risk, what does this mean? These are people who frequently engage in risk behavior. If you look at this chart, you'll be able to see that people who take frequent risk behaviors, and there are also people who don't frequently take those risk behaviors. And amongst the frequent risk behavior people, there are infected people and not infected people. So 2 times 2 means 4 boxes, and this covers all of the employees. So all the employees will be classified into one of the 4 buckets. First of all, what we need to approach, the population that we need to approach first is infected people who engage in risk behaviors very frequently. These people oftentimes don't know that they are infected with HIV. Without knowing that they are HIV positive, I don't think this is quite often in Toyota, but in general society, you share needles and you do engage in sexual activities without using condoms. So when you do that, you would be passing on the virus to non-infected people. So first of all, you need to deal with these people. You need to urge these people to take the tests to try to prevent secondary infection. So the next focus is going to be on these people who frequently engage in risk behavior, but they are not yet infected. These are people who are not infected yet, but eventually, if they continue to take risk behavior frequently, they will eventually be infected. So we want these people to migrate to this way. We would like these people to remain uninfected, but not engage in risk behavior so often. And for these infected people, if they are aware that they are infected, they may want to mitigate or minimize the number of risk behaviors. So the intent here is to try to make these people not engage in risk behavior so often. So the first target is going to be the people in this bucket who are frequently engaged in risk behaviors. And as for these 2 groups, they are going to be secondary. So the primary focus is going to be these 2 buckets. But in high prevalence area, even if the people are not engaging in frequent risk behaviors, the number is going to be larger. So in the case of South Africa, we need to deal with these people, even if their risk behaviors are not so frequent. So this is going to be the procedure. This is what we can do. First, you would focus on people who engage in risk behavior quite often. And we have to urge these people to take tests. If they test positive, then we have to provide a treatment to try to prevent secondary infection. And if they are testing negative, then we would like to promote prevention. And because South Africa is high prevalence area, we would also urge low risk group to take tests. So taking tests is going to be the first step for both of these groups, both high risk and low risk. And we need to find a way to promote test taking on a voluntary basis. And if we are able to identify who are high risk, it will be easier for us. And there's a number of constraints when we do this. First of all, high risk behavior is not directly observable by the test providers. So we have this problem of how we identify people who have high risk behaviors. And this is a South African law that you cannot force people to take tests, and you cannot directly ask people whether they are infected or not, because this is considered as discrimination. So this is not possible. And number three, because of strong labor unions are closely monitoring what the company does. So we cannot take actions which could be construed as forcible testing. Toyota in South Africa, let me just give you some background. This is a very important location in Toyota's global strategy, and they were operating in KwaZulu-Natal, which is a very high prevalence rate. The prevalence rate between 15 and 49 age is 25.8%. According to the World Bank study, it was 16.9, so this is quite high. So they had 7,000 people in their workforce. So if you do a simple calculation, it could be that as much as 1,800 people could be infected. And there were people who were dying from AIDS inside Toyota in South Africa. When we first started working there, this is the statistics that the health department of the company knew. The number of people with HIV was about 100 people, but the uptake rate of tests was about 40%. This was prior to our engagement. So we had two projects over a 2-year period. We had two surveys in 2009. We had one employees awareness survey in 2009. We asked them what kind of knowledge they had about AIDS, as well as whether they have ever taken tests in the past and what kind of sexual behavior they conducted. And the next test was conducted in 2010. We offered everyone the opportunity to take tests, and they were free to decline, and the information was to be kept confidential. We conducted tests, but along with the tests, we also conducted interviews as to what was the age and the height and the weight and the academic record, as well as we also conducted interviews as to their sexual behaviors. And from the survey that we conducted in 2009, we have been able to identify 2 inhibiting factors for people from taking tests. One was fear, because HIV is a life and death disease, so they didn't want to look at the disease head on. They wanted to delay having to confront the disease. This was what we have gleaned from the survey. And second is stigma. People were afraid that they will be discriminated against. They didn't want others to know that they are infected. This was a strong consideration because they were afraid that they will be discriminated against. They didn't even want others to know that they have taken tests. Not that they were infected, but they didn't want others, even that they didn't want others to know that they have taken tests. And when we talk about others, they were talking about colleagues. They didn't want their colleagues to know that they have taken tests, even. So these are the inhibiting factors. And the health service section had a high reputation for keeping information confidential. So employees knew that that information would not be passed on to HR division. Most of the people said that the health division is quite trustworthy in keeping information confidential, but still they were afraid that they would be, other people would end up knowing that they have taken tests. So this was a very deep-rooted concern that they had. And in 2010, we conducted a test promoting people to take tests. This was voluntary to let them know what their status was. And if they tested positive, they would be rendered treatment and they would be provided counseling, and they would be allowed to maintain their health condition as much as possible. And if they tested negative, then promotion for prevention was conducted. And we also tried to de-emphasize HIV. This was to be considered as one of the chronic diseases, and people needed not to be hesitant in taking tests. So we conducted some advertising that de-emphasizing HIV. Toyota was not the first example. There are other pioneering companies in South Africa. One is a mining company. They have live-in employees, and they have comprehensive lifestyle support. So they are able to take tests after working hours, so they can avoid people looking at them while taking tests. Second was the case of an auto company. People were commuting to office, and they needed to take tests during work hours. These companies were conducting a number of measures, but they needed to stop the production line. It was the directors and officers that took the test first, and general employees were urged to take tests as well. And as a result of these efforts, some companies had a high uptake rate of 95%. So what can we learn from this? Mining companies had live-in employees, so they were like a community, and they can have their employees take tests after hours. And they can also use the ability of HR as a company. And other companies are not able to copy what mining companies do because they have live-in employees. And in the case of an auto company, the consideration is whether they will be able to stop the production line every time. And it is not possible. The reason is some people have different cycles of taking tests. Low-risk people and high-risk people have different cycles for taking tests. For example, high-risk people, if they take a test today, they need to take another test the second time in 1 year time. But high-risk people, maybe they need to take tests in the 3 months time. Even if they are able to stop the production line, you will not be able to stop the production line so many times. So this is not sustainable to have people taking tests so often. So this is not sustainable for both of these high-risk and low-risk people. So this cannot be copied right away. And this is the concept of the test. We thought that the approach has to be proactive, inclusive, and we need to de-emphasize HIV. There was a change in national guideline in HIV. The purpose was to de-emphasize HIV, not to stir up fear. And what we mean by proactive is that if you just wait for people to come and take tests, nobody would come. So you have to be proactive. Inclusive in the sense that we need to be dealing with the stigma issue. We want to have as many people as possible to take tests. And we wanted to de-emphasize HIV to try to deal with the stigma issue as well. If everybody takes the test, you will not be discriminated against. So if you could make it look as if everybody took the test, then you can work around the problem of stigma. And we have adopted the opt-out solution. What this means is that when you go and take a health checkup, you do not ask people whether they would take an HIV test. You would tell them that the default is to take a test. Everybody else is taking the test. Would you like to opt out? You can. That is the question that we put to these people. So they needed to opt out if they didn't want to take a test. But the default was to take the test. And learning from the automakers example, directors and officers led this effort to take the test, and others followed. So how we implemented this is that the testing route was established in line with the jobs that they had. People working on the shop floor, they have to undergo mandatory medical surveillance program, and HIV test was added to that. For people working in the administration, medical surveillance program was not mandatory. So we created a new health program, which is called Health Consulting and Testing, and HIV test was added to that. In the case of people working on the shop floor, their program was called MSP, and as for people in administration, their program was called HCT, for Health Consulting and Testing. And in the case of a test, people spent the same amount of time in a private room. So these people would speak with a nurse to decide whether they would take the test or not. but they would have to spend the same amount of time in a private room. So from the outside, you would not be able to know whether they took the test or not. And this was voluntary. The information was kept confidential, and this was informed consent, and the production line was not stopped. And these are the results. At the planning stage, 4,252 people were targeted. The plan was to give tests to these people, but the test was offered to 3,318 people, and actually 2,686 people took the test. The rate was 81%, and 129 people tested positive. And they can be divided into two groups, MSP group and the HCT group, which is a newly created program. And these are the numbers here. If you divide this by race, these are African colored people, and these are Indian people, and these are whites and Asians. If you divide into these ethnic groups, the red solid line is the average number. African colored people, slightly less than 75%. Indians had high uptake of around 95%. White and others also high at 95% of uptake. African colored people, if you look at some breakdowns, people in administration had the uptake rate of about 90%, but people on the shop floor had less than 65%. So we need to promote a higher uptake amongst these people, African colored on the shop floor. We need to have these people taking tests more. So in questions, we asked about their subjective probability. We asked people about their own self-judgment about the possibility of their infection. This is 0 to 1 probability distribution. Here is a distribution where many people said the probability is almost 0. And here we had some people in 0.5 as well as 1. And the top graph is people who have taken the tests, and the lower is people who did not take tests. People who took tests thought that they were not infected. And people who did not take a test, more than 50% thought that they may be infected. This was the result of a subjective probability question. So our proposition, first of all, we should give people a reason to go to a test site. For example, telling them that everybody is taking tests and that this is part of the health checkup. And the second recommendation is that make sure that others will not be able to know whether they have opted to take the test or not. Next is de-emphasizing HIV, to consider this as part of a holistic healthcare program to treat HIV/AIDS as a chronic disease. This would make it easier for people to accept taking tests. And the healthcare program of Japanese firms is considered to be very high in quality. And targeting is how can we identify high-risk people? Well, we could look at the subjective probabilities. We can ask people about their subjective probabilities, and we should track them and offer tests as much as possible to these people. Subjective probabilities can be gleaned from interviews, and if you keep them repeated tests, you can pass on information about HIV/AIDS to these people. In the end, what should we do in the future? We need to understand the effect on people after learning about their status. After taking a test, and if you tested negative when they thought that they would test positive, would they engage in higher risk behavior? This has been pointed out in other research. So whether risk behavior has changed amongst the test takers should be followed up. And non-test takers, we would know about their status, but we should follow up about their absenteeism to check whether they are staying healthy or not. This concludes my presentation. Or lastly, let me just show you this. This is about the cost of these tests. Per head, it was about 8 million rand, slightly less than 8,000 yen. This was the cost for these tests. But as you can see from this, most of the costs come from nurses and receptionists, as well as supervision of the work. So half of this has to do with the research component. So the actual test provision cost was less than half of all of the cost associated with this. That concludes my presentation. Thank you very much.
伊藤さんどうもありがとうございました。
Thank you very much, Dr. Ito.